When to consider inborn errors of metabolism. These are considered rare, yet this reinforces the pattern of never looking for them, leading them to be likely massively underdiagnosed. As a disclaimer, I'm not a medical doctor, and this is not medical advice. The following is a slightly modified excerpt from my article on Substack for MasterPass members only, How to Interpret Ketone Ratios and the Lactate to Pyruvate Ratio, but it deserves a place on its own. By the way, don't forget to check me out on the Mitochondrial Energy Summit. More on that below. There are over 1,400 inborn errors of metabolism. Many of them are as rare as 1 in 100,000 incidents, give or take. Some might be 1 in 60,000, others might be 1 in 300,000. Yet these add up. So, for example, if we just assume in some back of the envelope math, just make this to demonstrate a simple point, that all 1,400 have on average 1 in 100,000 incidents, this would bring the total to 1.4% of the population. Not meant as an accurate number. It's just a simple demonstration that if you have many rare things as a category, the set of those rare things can collectively be quite common. Heterozygosity is extremely common and absolutely affects metabolism, even if it doesn't result in disease. I've argued in favor of its relevance in the full article that this is an excerpt from, but I will do so more comprehensively in the future. Here, I'm simply going to comment on when to look for diagnosable diseases, often but not always inherited in an autosomal recessive manner and thus requiring 2 copies of a defective gene. These should not be conflated with diseases about which nothing can be done. Many are treatable and some are curable when caught at the right time, and those treatments can be very relevant to nutrition, such as megadoses of a vitamin cofactor of an enzyme or a shift in macronutrients, such as keto diet or a low-fat diet, as examples. The main reasons to suspect an inborn error of metabolism are that other more common explanations for constellations of health problems have been ruled out, and systematic investigations of metabolism have revealed biochemical clues on such tests as amino acids, organic acids, acylcarnitines, acylglycines, and fuel molecules such as fatty acids, glucose, ketones, pyruvate, and lactate. These tests together will cast a huge net that will provide clues towards the lion's share of, though not all, inborn errors of metabolism. Onsets can range anywhere from in utero to old age. Proper diagnosis is hampered by 2 beliefs that are common but completely false. Number 1, inborn errors have onsets mainly in infancy and never in adulthood. Number 2, failure to capture the pathognomonic diagnostic patterns on the above mentioned test, quote unquote, rules out a disorder. Thus, between those two, underdiagnosis, misdiagnosis, and failure to properly follow through on diagnostic testing is common and, in my opinion, as a non-practitioner in this space, unfortunately the norm. For a full treatment of this issue, I would see the Saudubre textbook, Inborn Metabolic Diseases, Diagnosis and Treatment, which is now in its 7th edition, which came out last year in 2022. What is contained herein is largely drawn from that textbook. The patterns that I'm about to discuss do not rule in or rule out such a disorder, but the patterns present a opportunity to see the probability increased that the solution lies in this direction. So let's take a look at some of those patterns. And I know no infants are watching or listening to this, so I'm going to start with the adult onset. Adult onset inborn errors of metabolism often present with atypical psychosis, depression, unexplained coma, peripheral neuropathy, difficulty coordinating movements, intermittent paralysis of one half of the body, dementia, movement disorders, or epilepsy. Note the word or. You don't need to have all of these things. It's any of these things are often the onset presentation of an adult onset inborn error of metabolism. As noted above, whether there are other explanations that are more common is incredibly important. So if you get a traumatic brain injury and have epilepsy as a result of that, that is not going to be a high probability pointing this direction. Whereas if the epilepsy seems to come out of nowhere, that would be a very high probability pointing in this direction. Onsets that range from childhood to include adulthood are often associated with intermittent illnesses that are repeating, unresponsive to treatment, or note the words or, not and, or unexplained, often precipitated by immune events such as infection or vaccination, especially when accompanied by fever, or by prolonged or intense exercise, or changes in dietary nutrients that stress the faulty system. As an example of the latter, running marathons, eating keto, intermittent fasting, and MCT oil would all put significant strain on fatty acid oxidation. That's one system that could be faulty. Overdoing protein could stress the urea cycle, or any one or more than one of the many different pathways of specific amino acid catabolism. Eating carbs would stress carbohydrate metabolism. Megadosing thiamine or numerous other nutrients could stress the respiratory chain. Coma, strokes, stroke-like episodes, vomiting, lethargy, seizures, improper muscle tone, or difficulty coordinating movements are often, not always, involved. Psychiatric symptoms could include hallucinations, delirium, dizziness, aggressiveness, anxiety, agitation, or schizophrenic-like behavior. Developmental delay that does not recover as expected with time or treatment, mental retardation, and autism are often caused in whole or in part by inborn errors of metabolism. For infant onset disorders, the signs are extremely nonspecific, such as poor muscle tone, respiratory distress, poor suckling reflex, vomiting, diarrhea, dehydration, lethargy, or seizures. The signs are often confused with more common causes such as hypoxia or infection. Note this is not meant to say that if you see these, don't think of the more common ones like hypoxia or infection. It's just to say that if you only look for the more common ones, you might miss the more rare ones. Major red flags that are not needed to be present, but are simply major red flags that would push you even further towards the suspicion of an inborn error of metabolism. And I'm talking major red flags would be a sibling having previously died in infancy, or an infant relentlessly deteriorating despite treatment with no explanation. These need not be present, but are often present, and they might help add color to the very nonspecific signs that would otherwise be observed in infancy. For in utero onset disorders, about 30 to 40% of them lead to craniofacial abnormalities at birth. Note that the majority do not lead to craniofacial abnormalities. Some associated with the production of toxic molecules from food can make the mother sick from eating when she's pregnant, but not sick from eating when she's not pregnant. And this I pulled from a case report of a mother who had 4 babies. 2 of them, you imagine a mother and a father have both are so-called, I hate the word carriers because heterozygosity does affect the metabolism of the mother and the father, but they're carriers for the disease. And so they have 50% of their children wind up having the disease because they got the genes in the correct combination. And so 2 of her kids made her sick whenever she would eat the foods that provoked the negative response in her child. And in the 2 children that did not have the disease, she never got sick when she was pregnant. So this is not like a common pattern that you're going to be able to observe, but that pattern is an enormous red flag of an inborn error of metabolism that leads to toxic molecules accumulating from eating food, especially because it involves the characteristic pattern of recessive inheritance manifesting in the mother during in utero. Now, as I said before, inborn errors of metabolism can have their onset in late adulthood, and they do not need to have onset in utero. Respiratory chain disorders are a subset of energy metabolism disorders. And we could divide we could say energy metabolism is one thing. A subset of those is mitochondrial energy metabolism, and about half of that is errors in the respiratory chain. There are 297 distinct genetic defects that have been identified so far in the respiratory chain. And these have dozens of symptom clusters that you can describe in general a cluster of symptoms for a given one of the 297 defects, or for a category of those defects. Like you can say complex 2 is generally associated with these, and so on. But many patients have unique constellations that seem to be copied and pasted from the different clusters, making generalizations difficult. And as a result of that, the best way to summarize this is to pull from all the different symptoms and realize that a copy and paste selection of any of them could be a result of a respiratory chain disorder. Because energy metabolism governs everything with zero exceptions, if you have a primary defect in the root of all energy metabolism, the symptom clusters that are possible are infinite. And so it's important to recognize that symptom clusters are not very good at in terms of being diagnostic for anything once you get into this. But it's very important to realize that any form of copy and paste symptom cluster from this entire list, not having it all, just having this, and this, could very well be a respiratory chain disorder. You got to put it into the context of all the other overall patterns of testing and onset and history and all that. So the following is a highly abbreviated list. You can go to the Soderbergh textbook and you can go to the table in the respiratory chain chapter, and you can get a much more complete list. Peripheral neuropathy, stroke-like episodes, seizures, difficulty controlling movements, Parkinsonism, cognitive decline, drooping eyes, paralysis of the eye muscles, numerous types of problems with vision, hearing loss, and auditory dysfunction, cardiomyopathy, Wolff-Parkinson-White syndrome, which is a conduction defect that causes a rapid heart rate, pulmonary hypertension, defects in kidney function, liver failure, problems with gut motility, deficiency of pancreatic enzymes, chronic diarrhea, diverse forms of endocrine dysfunction, including diabetes and thyroid problems, low sex hormones, immune deficiency, various deficiencies of blood cells, including anemia, neutropenia, pancytopenia, exercise intolerance, rhabdomyolysis, excessive hair growth or baldness, fragile or twisted hair, bluish discoloration of the skin, loose skin, petechiae, which are pinpoint blood spots that reach the skin, and lipomas. Or lipomata is actually the plural of that. And now you have a problem where obviously you can have a cluster of these and it can very easily not be a respiratory chain disorder. But this is what happens when energy metabolism governs everything, and you're looking at disorders in the fundamental root of all energy metabolism in the body. Mitochondrial respiratory chain, as I said before, constitutes about half of mitochondrial energy metabolism, and in and of itself has 297 different known genetic defects. Many pharmaceutical drugs are respiratory chain poisons in vitro, and other such toxins can be found among food components, supplements, and environmental toxins. Among the many are the toxic alcohols, methanol, ethylene glycol, and diethylene glycol. When I say those are the toxic alcohols, not getting into a debate about ethanol, which is a relatively more toxic macronutrient than the other macronutrients, but that's another thing for another story. Another issue for another time. The anesthetic propofol, reverse transcriptase inhibitors, cyanide, salicylates, metformin, berberin, ciprofloxacin. A lot of people are taking a lot of things and eating a lot of things that are respiratory chain poisons. Now, since it's extremely rare to have a genetic disorder with 100% penetrance, which means that everyone with the gene gets the clinical presentation of the disease. Almost every genetic disorder has less than 100% penetrance, which means essentially that there's no such thing as a monogenetic disorder. And I've used this example before. If you go to something like cystic fibrosis, most cystic fibrosis genes have something on the order of 70% penetrance, which means 30% of the people that have the genes don't get the disease. And that's obviously because there's modifying factors, and those can be both be other genes and they can also be the environment. And when you have a genetic disorder that is 100% penetrance, that's probably a sampling error. And even so, there's nothing to say that the 100% penetrance in the current environment would be 100% penetrance in a different environment. So it's highly unlikely there's any such thing as a monogenetic disorder that has 100% penetrance. And if it doesn't have 100% penetrance, it's not a monogenetic disorder. So arguably, there's no such thing as a monogenetic disorder, even though there are disorders that are by and large best construed as monogenetic disorder for all practical intents and purposes. But the reason that I bring this up is that it's a complete fallacy to create a dichotomy between a genetic disorder and its environmental triggers, when in fact, it is highly likely that all genetic disorders are modified by the environment. And the stresses on the vulnerable system can be responsible for modifying the onset, which means that a disease that may have, in the absence of certain environmental triggers, may have onset at age 15 might instead onset at age 6 months or 3 years old or 4 years old. And because there are processes of development that happen in early life where things can be developmentally crystallized, this means that environmental triggers can bring inborn errors of metabolism backward in age and forward in time, so to speak, occurring earlier, into a developmental stage that makes that inborn error of metabolism create a permanent phenotype. For example, autism. It is extremely highly likely that all autism is caused by inborn errors of metabolism, but the environmental triggers in many cases did not make the inborn error of metabolism happen versus not happen. What they did was they brought it down in onset into the age at which the processes of brain development that are occurring means that energy failure at that time will trigger autism, and then the autism becomes a permanent trait. But environmental triggers can also be responsible for increasing the penetrance of the disorder in the population when they are imposed on a population. For example, through environmental toxins, or for example, through public health measures, which maybe aren't so good for public health, or whatever. Use your imagination. If you have, on a population level, a gene that in a particular environment, as I said before, leads to 70% penetrance, it may have led to 30% penetrance, 10% penetrance, or for some certain mutations, perhaps 0% penetrance in a different environment. And so it's a complete fallacy to say that because there's an environmental component, these aren't genetic. And it's a complete fallacy to say that because these are genetic, the environment doesn't matter. And it's a complete fallacy to ask the question, does X cause autism? When what X is doing is just, in a very generic way, the X's are collectively putting the stress on the system at a certain age that in the certain proportion of people who are vulnerable will have the onset of something either be more likely to happen in them, but more importantly, be more likely to happen at the particular time of brain development when that happening would cause autism. Anyway, if you suspect that you or a loved one have an inborn error of metabolism, you can seek out a local clinical geneticist. I would look for someone whose profile shows that they're actively publishing in their field. Anecdotally, I believe it's extremely common for people with inborn errors of metabolism to be turned away with an "I can't help you" when using this approach because that patient does not fit a cookie cutter set of pathognomonic diagnostic criteria. it's probably best to find high quality scientific papers about a suspected disorder, then find an author of one of those papers who operates a clinical practice in an area that's accessible to you, and then try to get an appointment with them. But that's probably going to be a bit like trying to get an appointment with House MD and winding up seeing Foreman, Cameron, or Chase, because I think the people, the more important they are, the more likely they are to be able to figure out your case. But the more important they are, the more demand is on them, and the more likely they are to filter out the people who they believe can be met by their team, and then have the people with the most serious or difficult to solve cases rise to the people with the critical expertise. Now, I am not an expert in this field, and I'm not a healthcare practitioner. I cannot diagnose or treat any of these diseases, but as a data analysis, you can hire me as a consultant to help discern probabilities from your data and provide educational help about action plans, especially as they relate to nutrition in the context of one of my consultations. If you're watching or listening to this as it's coming out, the Mitochondrial Energy Summit is currently ongoing. My friend and colleague Gabrielle Lyon is presenting today on the day that I'm recording this. Wendy Myers is tomorrow. Stephanie Seneth is Friday. Terry Walls is Saturday. Morley Robbins and I are on Sunday. And in that summit, a proportion of my talk does cover this issue, although the bulk of my talk is more about more common aspects of mitochondrial health. So I hope this helped raise awareness for something that is not something you want to look for everywhere, but something you certainly want to be aware of, because it's highly likely that most people know someone to whom this is relevant, given the fact that there are so many that, even though they are so rare as a group, they are not as rare as you would think. So hope this helps. Let me know in the comments if this generated any critical insight for you. I really hope it did. See you next time.